We'll begin with the next session on Clinicopathological Conference. Can I invite the chairpersons, Dr. Kartar Singh, Dr. Kim Vaipe, and Dr. A.C. Anand to please chair this session.
Adequate time for discussion. I think we should keep time, and I'll not waste much time in the introduction to clinical discussant, Dr. Sunil Taneja. He's a very well-known hepatologist from PGI Chandigarh, and stage is yours.
Thank you very much, sir. Good morning, everyone, and I thank INASL for giving me this opportunity. I'll be discussing the clinical protocol for today's Clinicopathological conference. The case for discussion today is a 40-year male, resident of Mandi, Himachal, and total duration of hospital stay was 8 days. And he presented with complaints of fever and jaundice for 3 months. Fever was high-grade, intermittent, documented up to 102 to 103 degrees Fahrenheit, and associated with evening rise and night sweats. No history of headache, altered mental status, rash, joint pains, bowel or urinary complaints. Jaundice was insidious in onset, gradually progressive, associated with high-colored urine. No history of clay-colored stools or pruritus. No history of pain abdomen, feeling of lump abdomen. There was history of loss of appetite and weight loss of 12 kgs over the last 6 months. No history of melena, hematomesis, abdominal distension, or decreased urine output. Past history, there was history of pulmonary tuberculosis in 2020, and this was treated with the ATT for 6 months. No history of diabetes, hypertension, or thyroid disease. He used to consume mixed diet. There was no history of similar illness in the family. He was evaluated for fever, jaundice, and abdominal lymphadenopathy in January 2024 in an outside hospital and started on ATT, which was stopped after 10 days due to worsening of jaundice. Visited PGI in end of April 2024 for further evaluation. Examination, he was conscious, oriented, vitals were stable. There was pallor, there was icterus, he had bilateral pedal edema. There was no lymphadenopathy, no cyanosis, no clubbing, JBP was not raised. Systemic examination, respiratory and cardiovascular was normal. Liver was palpable 6 centimeters below right costal margin, firm, smooth, non-tender. Spleen was not palpable, and CNS was within normal limits. These are the pre-admission investigations. This patient had pancytopenia. There was conjugated hyperbilirubinemia with low albumin. The ALK phos was markedly raised, and LDH was 309. Triglycerides were elevated, HbA1c was normal, thyroid function tests were normal, ferritin was elevated 1100, viral markers were negative, and chest x-ray was normal to start with. The ultrasound showed multiple lymph nodes in the abdomen, and these were non-calcified, non-necrotic. There was hepatomegaly, mild splenomegaly, and mild ascites. Pre-terminal and ultrasound was done, which was suggestive of enlarged liver. It was slightly irregular, heterogeneous with raised ecotexture. There was no intrahepatic biliradical dilatation. There was splenomegaly. The ascites became moderate. There was left pleural effusion, and portal vein became dilated, and it was 16 millimeter. 2D echo was normal in this patient. A whole body PET scan was done outside, which showed multiple lymph nodes in the mediastinum, multiple lymph nodes in the abdomen, the largest being 2.6 into 1.8 centimeter. Liver and spleen was enlarged. There was no FDG uptake in the liver and spleen. The gallbladder and pancreas was unremarkable. These were the investigations after admission. Again, there was pancytopenia. The platelets were markedly reduced now. Conjugated hyperbilirubinemia. Bilirubin rose from 5.9 to 16 pre-demise. AST-ALT marginally elevated, but ALK phos was markedly elevated in this patient. Hypoalbuminemia was persistent. INR was prolonged at the end of the illness. LDH was little elevated. CRP and procal was elevated pre-terminally. Peripheral blood smear, we have 2 reports. First one was kind of dimorphic picture. Second one revealed pancytopenia and normocytic normochromic red cells. Cultures were sterile. Urine did not show any proteinuria. There was no active sediment except for bilirubin. Pre-terminal, there was evidence of metabolic acidosis on the ABG. Course and management, this was a 40-year male patient presented with fever and jaundice of 3 months duration. Investigations revealed pancytopenia with conjugated hyperbilirubinemia and markedly raised serum alkaline phosphatase. With a provisional diagnosis of infiltrative liver disease and suspected sepsis, patient was started on IV ceftriaxone, hydration and supportive care. Post-treatment, the fever spikes decreased and night sweats decreased. However, the hyperbilirubinemia worsened. On May 11, the patient developed fever again. In view of worsening sepsis, cultures were sent. IV piptas was added. On May 13th, there was worsening, shifted to high dependency unit, and Vanco and caspofungin were added. He developed septic shock with hypoxia requiring oxygenation. Ultrasound was done to rule out biliary obstruction again. There was no IHBRD. With worsening hypotension and shortness of breath, he was mechanically ventilated. He experienced cardiac arrest and succumbed to the illness on 15th early morning. So the unit's final diagnosis was type 1 respiratory failure, septic shock, ARDS, severe cholangitis, intrahepatic cholestasis was, and cause of basic disease was infiltrative liver disease, query lymphoma. So let's look at the database of this patient. 40-year young male presented with prolonged fever, jaundice and night sweats, severe constitutional symptoms, had pallor, icterus and edema and examination, hepatosplenomegaly and ascites and left pleural effusion which developed preterminally. There was history of ATT intake in 2020 for pulmonary tuberculosis and 10 days for these symptoms back in January 2024. Let's see the investigations. He had pancytopenia, conjugated hyperbilirubinemia, mildly raised transaminase and LDH, markedly raised serum alkaline phosphatase, hypoalbuminemia, ultrasound and PET suggestive of hepatosplenomegaly and lymphadenopathy, raised procal, CRP and metabolic acidosis preterminally. To start with, this patient had cholestatic jaundice and there is strong evidence to suggest that. And for the sake of residence, these are the causes of intrahepatic and extrahepatic causes of cholestatic jaundice. So there's a big list of this. In my patient, I'm not considering extrahepatic biliary obstruction and intrahepatic mass as the cause of basic disease. There was no imaging evidence to suggest that. I would like to keep it as infiltrative liver disease. It could be a malignant infiltration or a benign infiltration like tuberculosis, sarcoid, disseminated fungal infection and amyloidosis, which I'm going to discuss subsequently. Could this be tuberculosis? Reactivation. Points in favor includes fever, lymphadenopathy, hepatosplenomegaly and constitutional symptoms. There was history of ATT intake in 2020 and this could be a reactivation as I said. TB is the biggest masquerader, can present like malignancy, can involve the liver, can involve spleen and it's a multisystem disease. The only oddity is to begin with jaundice and I presume that if he was adequately treated in 2020, he should not get it again. But then TB remains a very strong possibility in this patient. Sarcoidosis, it's a systemic disease. Liver involvement is seen in 70% of the cases. The liver functions are suggestive in this patient, but then there are no respiratory symptoms in this patient and no other system involvement. And we do not have ACE levels with us to support the diagnosis. So I'm not considering sarcoidosis in my patient. Disseminated fungal infection always remain a possibility in such a patient. The classical symptoms are there. And there are reports of disseminated histoplasmosis and other fungal infections presenting with fever and jaundice of prolonged duration. The only caveat here is it's usually seen in an immunosuppressed state and this patient was not having any immunosuppressed state to start with. And I don't have biomarkers to support any fungal infection in this patient. I'm not considering this possibility. I'll put my money on lymphoma in this patient. Obviously, he had these symptoms of fever, night sweats, anorexia, weight loss, painless lymphadenopathy. Hepatic involvement is seen in around 15 to 50%, splenomegaly in around again 50%. He had pancytopenia that would suggest maybe bone marrow involvement. LDH was also elevated. And there is history of ATT intake. If I presume that he didn't respond and he had this low-grade lymphoma which has now become really aggressive, I can keep this possibility. Though, again, the only oddity would be that the first presentation with jaundice, though it can happen in 3 to 20% of the patients and it's more common in non-Hodgkin's lymphoma as compared to the Hodgkin's disease. So my likely possibility is lymphoma in this patient. And could this be a primary hepatic lymphoma? Again, this is a rare form of lymphoma, usually presents with a mass in the liver and bone marrow involvement is classically absent and therefore I'm not considering primary hepatic lymphoma in this patient. I think this could be a secondary hepatic lymphoma. All the features are there to suggest that. So Hodgkin's versus non-Hodgkin's lymphoma, I think this could be a non-Hodgkin's lymphoma. It's more common than Hodgkin's disease. Extranodal involvement is seen in around 20%. Liver involvement is much more common as compared to the Hodgkin's disease. The only oddity which I thought here is usually presents in older patients and spreads in a less contiguous fashion. Let's look at the liver involvement in lymphoma. It can be due to direct infiltration, a paraneoplastic syndrome, VBD, bile duct obstruction. I'm not considering related to the treatment, and they can be miscellaneous causes like Budd-Chiari, hemophagocytic syndrome, and NRH. So let's look at the direct infiltration. I think this is a strong possibility in this patient. Typical presentation with progressive jaundice and weight loss, markedly elevated alkaline phosphatase, and as I said earlier, liver involvement can be seen in around 50 to 70% patients with non-Hodgkin's lymphoma. There's no evidence of biliary obstruction in this patient, no mass lesions also seen in this. So, can this be vanishing bile duct syndrome? Again, it's a rare complication, often has pruritus to start with. This patient never had pruritus, but rest of the symptoms and investigation would suggest that he can fit into a vanishing bile duct syndrome also. Again, that remains a possibility in this patient. Biliary obstruction is seen in around 1 to 2% of the patients. It's usually a malignant biliary obstruction caused by compression by the lymph nodes. Less commonly, you can also have primary bile duct lymphoma, primary or secondary lymphomas of the pancreas. The LFT pattern is suggestive that again, we have imaging which doesn't show obstruction. We just have ultrasound and a PET report. MRCP was not done in this patient. Sometimes sclerosing cholangitis can present like this, and there are reports that sonography might be normal, and when you do an MRCP, you can find multiple intra and extra hepatic strictures. So again, a rare possibility, but I'm not considering in my patient. So was there hemophagocytic syndrome in this patient as a cause of acute worsening? I think he would fit into HLH. There was fever, anemia, leukopenia, thrombocytopenia, elevated triglycerides, hepatosplenomegaly, elevated AST, ALT, elevated ferritin, and lymphoma is the most common underlying condition which can lead to HLH, and it may occur as an initial presentation also, or as a complication, or at a relapse of this disease. The only oddity again would be very high alkaline phosphatase. We don't have fibrinogen and the bone marrow report in this patient, and if we calculate the HLH score in this patient, it comes out to be 80 to 85%. So I think the acute worsening could have been due to HLH in this patient. So this is a case series of 30 patients. The association of fever, jaundice, and hepatosplenomegaly was present in 50% of the patients at presentation. And look at this, lymphoma leads this list, and Hodgkin's disease in 3, and these are the other causes which led to development of HLH. I think I have to discuss amyloidosis also in this case. We cannot get away without discussing amyloidosis. This patient had piledema and hepatomegaly. There was low albumin, raised alkaline phosphatase, and liver was markedly enlarged. And there is an association with lymphoma. The only oddity is presentation with fever and jaundice. There is no other organ involvement. We do not have the urine proteinuria, and we do not have a liver biopsy in this patient to make the diagnosis of secondary amyloidosis, but obviously it can coexist in patients with lymphoma. Drug-induced liver disease as a cause of acute worsening. Cholestatic liver injury is well known. There are a lot of patients who take CAM and herbal preparations, and we do not have the records of the treatment taken by the patient from January to May. But this patient didn't improve even after getting admitted, and we do not have a liver biopsy to suggest that it could be a drug-induced liver disease. But I'm not considering drug-induced liver injury in this patient. Was this patient having portal hypertension pre-terminally? I think that remains a possibility. He had piledema, he had splenomegaly, there was ascites and left pleural effusion. He had cytopenias and low albumin. Ultrasound showed slightly irregular outline. This was heterogeneous and raised echo texture. Portal vein became dilated at the end of the illness. I think this could be because of massive infiltration, and sometimes you can have nodular regenerative hyperplasia reported with lymphomas, and there are reports of that. I don't have the cytic fluid analysis and varicose screening to support the diagnosis, but then this remains a possibility that pre-terminally this patient developed portal hypertension. So what was the terminal event in this patient? I probably feel this was bacterial infection. He had cytopenias, raised procal and CRP, INR worsened, liver functions worsened. In spite of adequate volume resuscitation, there was a gradual increase in the need of vasopressors, hypoxia, and requiring mechanical ventilation, and finally succumbed to the illness. Another possibility could be that he has developed acute pulmonary thromboembolism, but then we do not have investigations to support that. So what do I expect from the pathologist? I think the basic disease is non-Hodgkin's lymphoma in this patient. The cause of cholestatic jaundice is direct infiltration by non-Hodgkin's lymphoma. It could be either vanishing bile duct also. I cannot completely rule out reactivation of tuberculosis in this patient. I think the acute worsening could have been because of HLH. And obviously, in such a case, disseminated fungal infection always remains a possibility for acute worsening. He definitely had severe sepsis, multi organ failure syndrome, and a cause of death probably was refractory septic shock in this patient. Thank you very much. I would like to stop here.
Thank you very much for discussing it so well. I'll now invite comments from the audience. And before anybody gets up, let me ask you one question. Uh, Fever and jaundice in tropics, would you like to consider any tropical infection like scrub typhus or melioidosis?
So I think typically they would present acutely, and fever going on for 3 months is a rare possibility. But then,
If they're untreated, fever can go on
yeah,
for 3 months in
yes,
both
high
these
grade fever.
conditions.
So malaria, Kala-Azar, and this can present like this. But then the generalized lymphadenopathy is not explained by
Occurs in
tropical
scrub
illnesses.
typhus. Yes, sir.
Very nicely discussed. Uh, for fungal infection, could we get a galactomannan and BDG as markers? And a bone marrow would have been helpful because he persistently had pancytopenia.
Yes, sir. I think that remains a possibility. But then the course of the patient was kind of very progressive, and he became sick before all the investigations were available for this patient. But then fungal infections in such a setting would always be a possibility. I agree.
Nice discussion, Sunil. But you are telling cholestatic jaundice.
Yes.
But this patient had no symptoms of cholestasis at any
That's
time.
an oddity, sir, that he didn't have that classical pruritus and the clay-colored stools. So this was kind of infiltrative disease which was causing this, though he didn't have this classical symptoms. I agree to that.
Excellent discussion, Sunil.
Can I carry on, please?
Yeah.
Yes,
So-
Mike one.
Yeah, so your possibility of hepatic infiltration by lymphoma, but your PET CT doesn't show any uptake by liver or spleen. So possibly there is a lymphoma, and this has precipitated HLH. In your final diagnosis, you have not mentioned HLH. So lymphoma precipitating HLH would
Yeah,
be.
acute worsening, I've kept it as HLS in this patient.
Mike
I agree.
two. Mike 2.
So I had a doubt. We don't have a value of GGT in this patient to differentiate whether that high ALP level was because of hepatic origin or could it be because of the bony involvement due to a malignancy.
So I think the presentation typically suggests cholestatic jaundice in this patient, but then agreed that we should have a GGT value in this patient, and bone involvement can also happen. So
And
that
sir-
could be contributing to the raised alkaline
And
phosphatase.
sir, my comment about the pre-terminal events would be rather than it being a sepsis because the procal is not that high. In this case, I would like to keep a possibility of a lymphoma with a visceral crisis. So if you look at the picture of the patient had a picture suggestive of ARDS during his pre-terminal stage, and there was worsening ALP, the liver function tests were worsening. All this could be because the lymphomatic cells were choking the sinusoids, choking the alveoli, everything. So that can lead to a picture which is similar to his pre-terminal event.
Yeah, point is well taken.
Thank you.
Sunil,
Mike
I
four.
have one question. Query. Yeah, here. The lymph nodes were palpable, right? Peripheral lymph nodes.
Peripheral were not palpable, ma'am. Mediastinal and abdominal lymph nodes were there.
I think it was written somewhere. Okay. FNA could have helped lots actually, and even I think guided FNA. I think the coagulation parameters were not very bad. Could have been.
Yes.
It could have been very helpful.
Mike 4.
Sunil, yeah, Dr. Poddar, nicely discussed case. I agree with you, everything is fitting with lymphoma. But again, I want to reiterate the same point. PET scan did not show any activity in the liver. Whatever is the infiltration, it should have been picked up. That is a very strong point going against the lymphoma diagnosis.
Any other comments? Would you like to say something
No,
more?
I think it's.
Yeah,
it's
yes,
okay.
ma'am. Again,
Okay.
brucellosis can present.
Sunil, I'll request you to come and join us here. And I'll request our pathologist, Dr. Subradeep Mitra.
Yeah, Subradev. Yeah, come on.
Yes. Thank you, ma'am. Thank you, sir. And Good morning, everyone. Before I start, I would like to extend my gratitude to the organizing committee of INASL for giving me the proud privilege to stand here and present before this August assembly. Right, so I'll be presenting the pathology counterpart of this very interesting case. So we performed a complete autopsy in this case, which means that we had taken out the thoracoabdominal organs as well as the brain. At the time of autopsy, the prosectors noted that the individual was thin-built and was icteric. The pleural cavities yielded approximately 100 ml of stroke-alert fluid in each. The pericardial cavity approximately 60 ml, and the peritoneal cavity had about 800 ml of stroke-alert fluid. So this is the organ complex. Sorry, just hold on. Yeah. So this is the organ complex comprising of a slice of liver, gallbladder, coelope of duodenum, pancreas, and the spleen. So the first thing that we observed in the slice of liver is it was massively enlarged, weighing approximately 2.7 kgs, whereas the spleen was enlarged approximately just double the weight of normal. Now looking at the liver, the obvious finding is these alternate areas of dark and pale zones, which I will be discussing in the microscopy. The capsular surface is very smooth. The liver cut surface was firm, it was not really foldable. And no obvious nodularity or no obvious space occupying lesion or mass could be appreciated. The portal vein was a little dilated, but there was no portal venous thrombosis, and the extrahepatic biliary tree was also normal. Now, this is the scanner view of the liver. So you can see the similar kind of dark and pale areas in the microscopy as well. And this is a Masson trichrome stain which highlights these dark areas or the deeply eosinophilic areas as well as the pale areas. Now these pale areas actually correspond to the portal tracts and a thin rim of periportal hepatocytes. So the zone 1 hepatocytes and a little expanded portal tracts represent these pale areas, in contrast to these dark areas which essentially shows centrilobular hemorrhagic necrosis. So the zone 3 as well as zone 2 hepatocytes had undergone significant degree of hemorrhagic necrosis, giving rise to the dark pattern in the gross. The reticulin condensation was focal, especially involving the zone 3 hepatocytes, and it was relatively preserved in the zone 1 or the periportal hepatocytes. So when we have a zonal hemorrhagic necrosis pattern, we try to look into the cause. And the one way of doing it is to look at the relatively viable area. So the viable area here relatively is the portal tract and the periportal rim of hepatocytes. And what you can see is that there is a very cellular infiltrate or cellular milieu in the portal tract, and the portal tract is a bit pale because of edema. Besides, I would also like to highlight one point. So this is the normal section of a normal liver. And if you look at the portal tract, the portal vein, the portal vein is the largest structure in the portal tract. So it is easily visible in a normal portal tract. But in this portal tract, in this particular patient, you can hardly be able to appreciate the portal vein because it's practically clogged by a cellular infiltrate. Further, multiple sections I'm trying to show to highlight this practical obliteration of the portal vein by numerous cells, and the cells or the cellular milieu I will describe later. And also in the portal vein you can see that there is an element of fibrinoid necrosis. In a few other portal veins where you can appreciate the lumen, but also you can see that the endothelial cells are very plump. They are lifted up from the basement membrane, and the intima of the portal vein is massively thickened by some myxoid material as well as a very cellular infiltrate. We perform Masson trichrome stain to highlight these findings, and you can see similar findings. This is a tangential section of a large portal vein which is clogged, and similar kind of cellular infiltrate, endothelial swelling, endothelium is basically reacting, and obviously fibrinoid necrosis. And possibly this venous occlusion or the venulitis had also caused some degree of cholangiocyte damage. If you majority of the bile ducts or interlobular bile ducts showed this kind of nuclear disarray, apoptotic changes in the cholangiocytes, which is also highlighted on cytokeratin 7 stain. Now we'll focus on the cellular infiltrate. So this is the tangential section of a portal vein, and you can see that the lumen is practically studded with multiple cells which look very, very different from the rest of the cells. They are not normal cells and we call them atypical cells. And these particular cells are studding at the endothelium, clogging the portal vein, along with a very reactive kind of cellular milieu, including lymphocyte, plasma cells, and numerous histiocyte at places, these histiocyte causing practically a granulomatous appearance. And these are the atypical cells, which are unilobed to multilobed, have some prominent nucleoli and abundant cytoplasm, and approximately 4 to 5 times the size of a mature lymphocyte. So we are obviously dealing with a lymphomatous process which has a typical angiocentric and angioinvasive kind of pattern, and it has invaded practically the portal veins, destroying them in this process. And looking at on the higher magnification to these lymphomatous cells, looking at this particular cell, they have very prominent nucleoli. Somebody might think of an owl eye appearance. And looking at this particular cell, somebody might think of a mummy or mummified cell. There are various other patterns also in the liver. So at some places, which are the focal patterns, not the dominant pattern, there is obvious clustering of these lymphomatous cells within the lobules. Sometimes these lymphomatous cells are seen traversing the sinusoids. Also, other than centrizonal areas of necrosis, there are foci of periportal necrosis, and at places there is also panacinar necrosis. And obviously, the liver showed florid evidence of hemophagocytic lymphohistiocytosis. There is a lot of lunch and dinner going on by the macrophages, which are practically a big blob-like macrophage containing multiple erythrocytes. Because there was a hemorrhagic necrosis pattern, we also subject the tissue to multiple immunohistochemical panel for the viruses, including HBC, AG, HSV1, HSV2, and adenovirus, and all turned out to be negative. So obviously we are dealing with a lymphomatous process, and to diagnose what lymphoma it is, we looked into the multiple lymph nodes, dominantly the retroperitoneal lymph nodes, the largest of which measured approximately 3 centimeter in size. Beside there were para-aortic lymph nodes as well as iliac group of lymph nodes. So when we looked into in the low magnification towards the lymph node, it is dominantly completely effaced with bands of collagen fibers and these atypical lymphoid cells which are scattered here. And at places with more preserved lymph node areas, there is partial effacement with band of fibrosis. And we can see that there is a very reactive milieu in the lymph nodes, including lymphocyte, plasma cells, occasional eosinophils, along with these characteristic cells, which now we will be calling as monolobular cells or Reed-Sternberg cells. And these cells are CD45 negative, CD3 negative, 20 negative, and there is dim expression of PAX5 in these cells. Also, the characteristic membranous and Golgi zone accentuation pattern in CD30 and CD15 stem. And also, these cells showed Iberish positivity, which is the EBV encoded RNA, confirming this to be a classic Hodgkin lymphoma nodular sclerosis type, which has infiltrated the liver. Now let us look into the other components of the reticuloendothelial system. So this is the slide of a bone marrow. I am able to see that it's a very cellular marrow with some degree of trabecular thinning. So I think Dr. Ashwin was referring to some degree of erosion of the trabeculae, so which is a possibility. However, bone marrow is cellular not because of infiltration, at least in the post-mortem time, but showed a very, very florid hemophagocytic lymphohistiocytosis. Whichever cell you are seeing in this particular field is almost all are macrophages, and many of them containing hemophagocytic figures. The spleen, which was enlarged, dominantly showed a lymphomatous infiltration in the red pulp area, as well as some places white pulp areas are involved by the lymphomatous process. Besides, this patient had a history of tuberculosis, and in the spleen we could find a focus of fibrocaseous tuberculosis, although AFB was negative in this. Another lymph node in the peripancreatic area also shows this focus of caseation, which was also seen microscopically. Now, the lungs were very heavy, 1.7 kg in weight, which is nearly 2 times the normal weight. And you can be able to appreciate that there is dullness over the pleura. And also the right upper lung showed this area of fibrocaseous tuberculosis, which was seen microscopically also, and again AFB was negative because the patient was well treated, but tuberculosis PCR was positive in the lung sample in our medical microbiology department. Now, why did the patient die and what was the reason for this very heavy weight in the lung? It's diffuse pulmonary hemorrhage. So we have obtained multiple sections from both lungs, multiple lobes, nearly 12 to 15 samples, and all of these samples showed extensive intraalveolar pulmonary hemorrhage in this individual. Besides, if you remember, the previous owl was a different owl. This owl is a different owl. Here also we found some owl's eye appearance, but this is CMV inclusion, and this is not the Reed-Sternberg cell. And this is a different form of owl eye that we have seen. Also, there was an incidental pulmonary hamartoma in the lung. The kidneys weighed approximately 240 grams. The corticomedullary junction was distinct. It was almost normal kidney, apart from some degree of swollen kidney structure. The glomerular compartment was normal. However, there was bile cast nephropathy and evidence of moderate degree of acute tubular injury. The heart weighed 220 grams. All the chambers and valves and the coronary arteries were normal. The esophagus, stomach, small and large intestine were grossly and microscopically unremarkable, and so also was the brain. Various other organs like pancreas, adrenal, thyroid, testes and skin was normal. So this is my final autopsy diagnosis. We are dealing with a classic Hodgkin lymphoma nodular sclerosis, which has involved the retroperitoneal, para-aortic and iliac lymph nodes and infiltrated the liver and the spleen. In the liver, we are seeing a very peculiar pattern of infiltration, which is angiocentric and angioinvasive, especially involving the portal veins. There is obvious multi-acinar centrilobular hemorrhagic necrosis, which is likely to be multifactorial. At least partly it is contributed by this venulitis kind of changes, and obviously this disease was complicated by secondary hemophagocytosis, which was very florid in bone marrow, liver and spleen. There was diffuse pulmonary hemorrhage, old healed fibrocaseous tuberculosis, CMV pneumonitis and an incidental pulmonary hematoma, and there was also evidence of bile cast nephropathy and acute tubular injury. So before I finish, I would like to draw your attention to a few points. Number one, how common is Hodgkin lymphoma or classic Hodgkin lymphoma infiltration into the liver? According to this meta-analysis, it is just 5%, and these are obviously stage 4 disease. Dominantly, as Dr. Sunil had already mentioned, that it is non-Hodgkin lymphoma which infiltrates the liver. The second is, what is the common pattern of Hodgkin lymphoma infiltration? We see biopsies as well as from our autopsy experience, we see a lot of Hodgkin lymphoma infiltration into the liver, but majority of the time, the pattern that we see is the portal-based pattern and a loose pattern, but this angiocentric, angioinvasive and venulitis-like destruction of the portal vein is something which is very odd, and we have previously seen this pattern in another case almost 8 years back, where you can see again similar kind of venocentric and veno-infiltrative patterns, but with dominantly periportal necrosis, and this case actually presented as ALF, unlike this particular case which presented with elevation of alkaline phosphatase. The last point that I want to mention is what are the different patterns of hepatic infiltration by lymphoma which causes hepatic injury. So the first one is obviously large vascular or biliary tract obstruction by lymphadenopathy, which was not present in the index case. Sinusoidal clogging by lymphoma cells. There were a few lymphoma cells in the sinusoids, but it was not clogging the sinusoids, so this is also not present. Sometimes the lymphoma becomes a mass-like lesion and infiltrates the liver, replacing the hepatocytes, causing acute liver failure. There are case reports to it, and this is also not the case in our index case. However, what we saw was portal vein infiltration by lymphoma cells, one of the rare patterns of classic Hodgkin lymphoma infiltration, possibly which has led to small duct damage and cholangitis-like picture. So 30 seconds for the last slide, which is my thank you slide. This is a panel of 10 different owl's eye. We have seen 2 different owl's eye in the realm of pathology today. 10 different owl here, the wisest of them. 4th August was the International Owl Day. And if you go around Chandigarh, who have come to Chandigarh for the first time, these owls can be seen in and around Chandigarh, and these are the 10 varieties which I have clicked in and around Chandigarh. Thank you.
Thank you,
Thank you.
Subhadip.
Thank you very much, Subro. And it was a wonderful demonstration. I just want to ask you about your last slide of the owls. Is it your own photograph or it's downloaded? Because he's a good photographer. He's about Wurzer, actually.
You can't
Is it
say
your
it is
own?
his own photograph.
Your own? Yeah, wonderful. Yeah, that's really remarkable.
Thank you very much.
Now, I think coming back to the today's CPC case,
Yes, yes.
yeah, I'm just being intrigued. I think the last slide where you crossed out some of the points, you were mentioning about a portal vein infiltration.
Yes, ma'am.
So, what was the size? The main portal veins were involved, or
Yes.
intermediate or the small ones?
Right. So, ma'am, these are the small and intermediate ones. The main portal vein was not involved. We have obtained sections from those, but those were the portal venous radical. I mean, the small and intermediate ones which were infiltrated and clogged by the lymphoma cells.
So, what would be your hypothesis for involvement of the endothelial cells of the portal system?
Yes. So, what I believe, when we see such angiocentricity, we evidently see in different other lymphomas which develop some form of homing receptor to the endothelial cells and the smooth muscle cells of the intima or the fibroblast. So possibly a very small subset of classic Hodgkin lymphoma cells develop these receptors and tag the endothelial cells or the underlying fibroblast, causing this peculiar pattern.
Is it been described only with Hodgkin's, or it's also been
No, ma'am,
described
it is
with other?
not described in Hodgkin. It is described in other lymphomas like extranodal NKT cell lymphoma, which typically show such kind of pattern.
Okay, thank you. Anybody?
Before I ask the
Oh,
audience
so many
to,
hands.
before
Please
I ask
do.
the audience to speak,
Acha, he
I
wants to
think
ask a
you
question.
should give a chance to Sunil to give his comments.
My comment is regarding tuberculosis in this patient. I am not sure whether this patient had active tuberculosis. You said the PCR was positive and there was some cavity lesion somewhere. So can you just talk about it?
This was definitely an old hill tuberculosis. Sometimes when AFB is not positive, but PCR brings out the treated ones, the DNA is still there, and that is what I was trying to show, but it was definitely not active.
There was a very old saying that tuberculosis follows Hodgkin's like a shadow.
Yes.
But you are showing that Hodgkin's has followed the tuberculosis in this case.
So this PCR was still positive,
Yes, ma'am.
right?
Yes, ma'am.
So what would be your take on that?
Yes, that's actually a little difficult to explain. It was not an active focus, I can say, ma'am, but obviously it was recently treated. The DNA must be still surviving, and given the chance, if the patient survive, probably this would react.
Yes, Abba, your comment.
Okay, yeah. Dr.
Yeah,
Naira?
thank you, Dr. Suradeep. I'll really like to know where these owls are in different parts of Chandigarh, but we can talk about it. The question I had was that this patient did not have any FDG uptake in the liver and spleen, though you've shown, and we know that lymphoma causes a very avid FDG uptake. So, is it the pattern of liver infiltration which determines whether there will be FDG uptake or not? Because you nicely described the various patterns. So is that what, because we still can't explain why there was no FDG uptake?
So, responding to your question, ma'am, dominantly when we see lymphomatous infiltration in the liver, we see mass-like lesion. But here, if you see that practically the lymphomatous population, number one, in classic Hodgkin, this reactive population is the dominant one. The lymphomatous population is the smaller one. I mean, in the dominant reactive background, there are a few cells, number one. Number two, if we look at the pattern of infiltration, there is no mass. And even in gross, there was hardly any mass. And that's why I believe that PET did not show it is the typical uptake what we usually see in non-Hodgkin lymphoma or other lymphomas.
Okay, thank you.
Hello, sir.
Thank you for such an elaborated presentation. And my question is for Subradeep. There is lot of bile duct damage. So are these the atypical cells, or is there any bile duct loss or vanishing bile duct syndrome
Yes,
in
so
this?
there was no bile duct loss. So in whichever, that's why we did CK7 to see whether there is actually any vanishing bile duct. I was able to see that there are a lot of duct damage, but not by the atypical cells.
Okay.
There is duct cholangiocyte apoptosis, some degree of nuclear desire, cytoplasmic evacuation, but nowhere atypical cells have breached the basement membrane and gone to destroy it. So one possibility could be that the reactive milieu around the Hodgkin cells have caused this damage, number one, and number two, it could be the vascular event which has possibly caused this damage and kind of ischemic, ongoing ischemic injury to the bile.
Ischemic changes could be the cause.
Yes, Mike too.
Okay, thank you.
Yeah. Please introduce yourself. That would be nice.
I'm a medicine resident from AIMS Bhubaneswar. Sir, actually, HLH is a clinical and biochemical diagnosis, sir. You have already suspected in this case. Have you considered IVIG or Plex with broad spectrum antibiotics in this patient, sir?
I think that's the clinician's decision, and this case was not admitted with us. So I am not aware that he was considered for IVIG or not.
Okay, thank you, sir.
Sir, question to Sunil sir. Shura sir has shown in the liver pathology sections, the major involvement was a portal based involvement. But in our case, there was a pre-terminal worsening of ascites. It was a clinical ascites, and they also found, the prosectors also found that almost 1 liter of fluid was there in the peritoneal cavity, and there was also fluid in the pleural cavity also. So, do we expect, is there a matching between the clinical and pathological picture? Because usually the classical teaching is that in an acute PVT, there can be mild transient ascites, but in our case, there was moderate clinical ascites, which we expect in a sinusoidal involvement or like a Buchieri like phenotype or a veno-occlusive disease like phenotype. Are we expecting ascites? What explains the ascites in this case?
So actually, I had kept the possibility of portal hypertension because of various reasons which you have described. But then, classically, if you see, there was some dilatation of the portal vein, and there was infiltration by the tumor. So whether this tumor's cells was causing that increase in the portal pressures and leading to portal hypertension, I mean, that remains a possibility. I think that would explain the only reason would be that, I think.
I think I have some, I like to add some more, okay? Actually, veno-occlusive disease involves the central veins, not the portal veins. And besides that, at the time of autopsy, certain amount of ascitic fluid, that was less than 1 liter? Yeah. That could be just a transudate, right? May not be really very significant. And the patient was grossly hypoproteinemic. That itself also will produce that amount of ascitic fluid. And besides that, these patients are admitted in the hospital. They are under 24 hours medical care. So you cannot really see the fluid conditions or the pathological changes, because they have been treated. They are constantly under supervision in the hospital. So one has to all the time take the plus and the minus points of those cases who are dying in the hospital. And I think our hospitals, especially in PGI, the patient cares are so good, the intensive cares are so good. They get the best, I would say, the best treatment. We are very proud of it. Yeah, we are very proud of it. Definitely, we have very good set of clinicians in our hospital. And I would like to sing something about them. That's all. So I think one has to all the time take into consideration various factors, just not one point.
I think with that, we'll close the session, and I'd like to thank both the clinical and pathological discussion for excellent presentation, and my co-chair for chairing it so well. Thank you.
Thank you to the chairpersons and the speakers. Please join us for a photograph. Dignitaries, we are having a tea break now, and we'll resume the sessions sharp at 11 a.m. Thank you so much.